first of all, I think that we need to think about the basic science. When we think about the benefits, you need to think about how it's working. So we just had a paper published this week, actually, well, September 29th, 2023, in Nature Communications. And I would recommend that people look at that because we've shown very clearly that, and this is extending on work that's been done before, that estrogens can act on the hippocampus to specifically acting on astrocytes, and specifically you can bind to ER beta, estrogen receptor beta. So you don't have to bind to ER alpha very strongly and get these off-target effects of, for example, on breast and so forth. This situation should be taken much more in a standardized way that pharmaceutical companies do. You want to maximize the efficacy and minimize toxicity. So when you say benefits of HRT, the question is, well, which one? Because type, timing, dose, all of these things matter, just like interferons, actually. Alpha and beta interferon versus gamma interferon. I mean, they're completely different. Type, dose, high dose, low dose, it matters. Timing, it matters. All these things matter, not just for the interferons, but for most things actually in pharmaceuticals. And in this case, they certainly matter with the estrogens. And so there's ample evidence both in preclinical models, and then we've done a lot of work with estriol in MS patients, showing in a phase 2 trial exploratory outcomes that they improved in cognition, they had decreased cortical atrophy, and that they had a decrease in serum neurofilament light chain. But again, that's using an estrogen that is designed to act on ER beta and have these off-target effects of ER alpha, because you can't treat with ER alpha ligands like estradiol patches and then Premarin is such a low dose of a mixture of hormones. It's not sure what's happening with those because it's just a mixture of pregnant male urine proteins. So we have to be very selective, not a mixture that's been around for 40 years. We don't know exactly what's going on, and it's low dose. And then when you come to something like estradiol, it can have neuroprotective properties, but you cannot take that at a high dose, any sort of a high dose, and you certainly are told not to take it longer than 5 years. And so these are not solutions. So the solutions are to do better neuroscience based on efficacy and tolerability of what the HRT should be. Well, what we want to do is we want to do a trial of estriol, again, binding ER beta instead of ER alpha. It's actually the estrogen of pregnancy. We know pregnancy's got beneficial effects in MS. We've done this before in younger women, mean ages around mid-35 or so. And so we want to do this in a very important group, and that is this menopausal group where they have worsening disabilities. So what we'd like to do is a multicenter trial giving estriol at a mid-pregnancy dose, and the primary outcome measures would be, again, sparing cerebral cortex atrophy and improving cognition. And actually, we've got some evidence that serum neurofilament light chain and other blood biomarkers could work. But the primary outcomes are to prevent cerebral cortex atrophy and to improve cognition. That's not to say that it won't work on other disabilities as well. This is just what's been shown. There's evidence in healthy women. They have cognitive issues during menopause, and so you can show that could be affected readily. But this is not mutually exclusive of other disabilities being improved as well. Preclinical evidence shows that estriol ER beta ligands can act on spinal cord. You could imagine, of course, improved walking disability. So these other disabilities aren't excluded. And so we really want to focus on, again, trying to do a trial where we prevent this disability worsening in MS women as they go through menopause. And we want to do it by using a neuroprotective estrogen, namely an ER beta ligand. And again, not to treat just hot flashes for a few months. Hot flashes, they're not, again, the whole world is focused on hot flashes and for very short-term symptomatic treatments. It's more than that. We need to focus on the neurodegenerative mechanisms, and we need to come in and try to repair those. And that's going to be a strategy like we know in MS. It's not easy, and you need to focus on MRI markers, blood markers, clinical outcomes, and treat for at least a year, maybe 2.